Hi, my name is Taniqua Newkirk. I researched the topic, does constraint-induced therapy improve upper extremity function in children with cerebral palsy? As an occupational therapist, our focus is to increase daily function despite disabilities in the persons we treat. There has been statistically significant results provided in the research that the use of constraint-induced movement therapy, also known as CIMT, to improve upper extremity function. As an occupational therapist, the determination of the need to use CIMT should come from the potential for effectiveness and suitability of the child with cerebral palsy. CIMT has been shown to affect the child's use and daily tasks in order to increase independence. Treatment also involves the use of supplemental therapy sessions or home programs, which adds to the overall improvement. As a researcher, the next step I would take is developing a specific protocol to provide better grounded evidence in its effectiveness for this population. There also could be a push for the use in clinics by providing this knowledge to other professionals and families. The first article I used was by authors Abdi El-Khalfi et al. It was a level 2 evidence which used a randomized controlled trial pre-test post-test design. The children had congenital hemorrhagic cerebral palsy. The intervention group used CIMT with a sling while performing gross and fine motor tasks and shaping. The control group performed gross and fine motor tasks with no constraints. Both groups included a home program. Outcome measures used were the pediatric arm function test, quality of upper extremity skills test, Biodex System 3 Pro multi-joint testing and rehabilitation system. The article shows statistically significant data between groups for the Quest and the peak mean torque of shoulder muscles, all favoring the CIMT group. The limitations of this study were recruitment bias, there was no power analysis performed, and participants were aware of the treatment methods. The second article I used by authors Dave Brando et al. For level 2 evidence using a randomized controlled trial pre-test post-test control group with follow-up. The children had spastic hemiplegic cerebral palsy. The intervention group received CIMT with a sling and hand resting splint while performing functional tasks. This was followed by bimanual training in functional tasks. The control group received regular occupational therapy, performing bimanual functional tasks and sensory stimulation. The outcome measures used were the Jepson-Taylor hand function test and the pediatric evaluation of disability inventory. This article shows statistically significant differences between the groups for all pediatric evaluation of disability inventory scores. These favored the CIMT group. The limitation of this study is they lacked a true control group, lack of possible replication in regards to staff parameters, and a small sample size. The last article used in this research was by authors Wallen et al. It was a level 2 evidence using a randomized controlled trial pre-test post-test with follow-up. The children had spastic hemiplegic cerebral palsy. The intervention group used intensive occupational therapy with a home program and CIMT with a fabric mitt. They performed functional movements needed for ADLs. The control group used intensive occupational therapy with home program, including motor training, stretching, casting, and functional activities. The outcome measures used are the COPM, Goal Attainment Scale, Assisted Hand Assessment, the revised Pediatric Motor Activity Log, the Modified Ashworth Scale, and the Modified Tardif Scale. There were no statistically significant differences within any data. The limitation of this study, there was a lack of control group. Treatment of both groups at the same location could cause a possible bias. There's a variety of research on this topic for upper extremity function in children with cerebral palsy. Some evidence suggested that it may not be more effective than any other traditional method, but there was sufficient good evidence that overpowered the assumption and supported the use of CIMT. Future research needs to be focused on specific protocols that include application times, activities, and adjunct therapy, as well as include larger populations of children with cerebral palsy. I was able to determine that CIMT is effective through research on this topic. Thank you.